All right, let's turn to Chapter 9. We'll start with the end. We'll start with the answers for page 160. So Medicare is made up of two primary parts. But what are the four common services Medicare Part B does not cover? So what are four common services that Medicare Part B does not cover? Kelly, do you have any idea? What would you say?
Did you say Kelly?
Yes. Okay, well, some of the services that might not get covered would be cosmetic surgery, eyeglasses, routine dental care, dentures, hearing aids, exams for those fitting of the hearing aids, acupuncture, that type of stuff. Number 4, what type of service does Medicare Advantage cover that original Medicare does not cover? That would be depending on the plan. Coverage may include preventative care, prescription drugs, routine eye and hearing exams, dental care, but make a note here that the original fee-for-service Medicare does cover specific preventative care. We would have to refer to the Medicare and You handbook in order to know exactly what they cover. All right. Page 163. Page 163, number 2. Categories of people make up the dual eligible classification. What categories make up that dual eligible classification, Kelsey?
People enrolled in Medicare and Medicaid?
Yes. Yes, and those who are low income or under 65 with disabilities. All right, number 4, how many standard Medigap policies are currently available? That would
10?
be 10, yes, good job. Okay. Number 6, name the 4 payers that typically would be primary to Medicare. There's actually a list of them, but Kelsey, give me 2.
Workers' comp?
Yep.
And VA benefits?
Yep. And then some of the others would be the working aged who are covered by a group health plan through their own or their spouse's current employment. So here's a perfect example, and I think I gave you one last week, but I had a patient over the last few weeks come in. It's a woman of 65 years old. They assumed that she was Medicare, but she's not because she is still working. So she actually has an Anthem plan and a Medicare plan. And in this instance, Medicare is not the primary because she's still working. Okay. So you're going to have to pay attention to the payers and the plans, and when in doubt, always call the plan and say, are you primary?
Okay.
Okay. A couple others might be Black lung disease covered under the federal Black Lung Program, federal research grant programs, disabled people age 64 and under. Okay. All right. Page 7. Number 2, page 167, number 2. When patients enroll in a Medicare managed care plan, they typically agree to choose healthcare providers from an approved list called a network. Yes. And has a higher enrollment, traditional Medicare or Medicare Advantage.
Advantage? Are you still there?
Yes? Can you hear me?
Yeah, it's cutting in and out. I can see and hear Kelly, but Doreen, I don't know if you're still there.
Aren't you working? Can you hear me? Can you hear me?
I can hear you.
Okay, just want to make sure. For some reason, my other speaker isn't working.
Can you hear Doreen?
No, I can't.
Yeah, she's frozen on mine.
On mine, she's frozen. Yeah, mine too.
But I can see the other girl, so I don't know if it's her connection.
Oh, looks like they're having some
Come on.
technical difficulties. Hello?
Hello?
Can you see Gardner?
I can see Gardner, yes. I don't know where Doreen
Yeah,
is.
so I guess
Okay.
maybe it's hers.
Maybe.
That's something wrong.
Yeah, I think so. Okay.
All right, then I'll just wait to see if she calls back.
Okay, if not, it might just come on
Yeah.
without even calling.
Yeah.
That has happened. If not, in a few minutes, holler to me and I'll call the
Okay.
network place.
All right, thanks.
Thank you. I know sometimes I have trouble connecting. I don't know what it is.
Yeah, I know it seems like it's not easy to do connecting from home for the live class.
Well, my other class I took, I was able to connect no problem. For some reason, I get cut out with Doreen's. I don't know why.
Yeah.
I don't know if it's connection or I don't know what it is.
It must be, but since you and I can see and hear each other, I think it must be her connection.
Yeah. Yeah, because before, when I first got back on, she was cutting in and out too.
Yeah.
And then go off on camera.
She didn't like the cops because she didn't like that I was younger. And I knew what I was doing. She had to learn from me. I know. But I want to. You feel it. I'm sorry. You can make it as long as you want it, right? I know this way you come in. It's just pull up. And then it just goes together. So it's magnet. Oh. Magnet. I made it so that it said, the instructions said 16 inches. But. That is really pretty. But I didn't print off the instructions. Because it's changed. Oh, how? They're on the computer. In my email. It's easy enough. But, so what they're gonna do every time they do a chain, they're gonna do a chain around the bead. Put the bead in. I mean, I have it right on my email. So, I mean, good job.
Hello.
Okay, so maybe it's my turn tonight to have problems. Okay,
Welcome to my phone now.
so I have network main on speed dial. All right, so we were on page 167. And we were answering number 4. And which type of Medicare plan has a higher enrollment, traditional or Advantage? And I said traditional, and that is because your Advantage plans tend to have a higher out-of-pocket dollar amount than your traditional plans. While your premiums may be lower on the Advantage plans, your out-of-pocket payments are more. Okay?
Okay.
All right. How about page 170, number 2. Kelsey, what's the number 2?
Local coverage determinations.
Yes, and what do they consist of?
Info that has to do with when a procedure is considered medically necessary and reasonable.
Okay. And number 4, how is the HICN structured? Kelly, did you do that?
It is a format of 9 numerical characters, usually the beneficiary social security numbers, followed by
Yes.
1 alpha character.
Yes. Okay. All right. Let's turn the page, 172. Number 2, list 3 advantages of becoming a Medicare Part provider. The Medicare fee schedule is 5% higher than that of non-participating physicians. They are provided with toll-free lines if they submit claims electronically, and their names are listed in the Medicare participating physician and supplier directory, which is finished to senior citizen groups. All right. Page 175, number 2. The date for full compliance for the implementation of version 5010 was what, Kelsey?
I think January 16, 2009.
Actually, June 30th, 2012. All right, number 4. What is the revised deadline for filing Medicare claims? Kelly?
I have, it begins on October 1st and ends September 30th of the following year.
you're you're on the right track. Basically, the Patient Protection and Affordable Care Act implemented or included a provision that limited timely filing of your Medicare claims to 1 year from the date of service. Okay?
Okay. I saw that too, and I wasn't sure if I was right.
Yep. You were on
Okay.
the right track. How's that?
You.
Okay,
Okay.
page 179, number 2. Number 2, Kelsey, is it true or false?
I said false.
That is correct. It is false. Number 4, name 3 circumstances under which Medicare may be the secondary insurer. Kelly, what do you have for that one?
I have group health plan coverage, working age disability, large group health plan, and ESRD, no fault or other liability insurance, and work-related illness injury workers,
Yes.
compensation.
So the 3 circumstances, group health plan, no fault, and work related. Number 6, Kelsey, what do you have for number 6?
11A, 11B, 11C, and 11D.
Correct. All right, page 182.
Okay.
Go ahead. Go ahead, Kelly, what?
Well, I also thought look 11, or is that not part of 11 through 11C?
Give me just a minute.
Okay.
I don't have a claim form right in front of me.
Oh.
I'm one of those people, I have to see the form.
Oh, yes, I understand.
Um, 11 would be part of that, but really it affects 11A through D.
Okay.
Okay, page 182, number 2, explain the difference between the MSN and the Medicare RA. What do you have for that, Kelsey?
I said the MSN gives a breakdown of claims billed on patient's behalf and processed by MAC, and the RA is a notification that Medicare sends to the provider and includes the list of all claims paid, rejected, or denied.
Correct. All right, what is an electronic funds transfer? Kelly?
You just answered it.
Transfer is a payment that Medicare automatically deposits to a provider's designated bank account.
Yep, it's an EFT, electronic funds transfer. All right, page 187. Number 2, list 2 things that might prompt a Medicare audit. Kelsey?
Prior problems or unusual billing patterns.
Yes. Number 4, Kelly, under what circumstances might a provider initiate an appeal?
He or she did not accept assignment on a claim that denied on the basis of not being reasonable and necessary.
Okay, so basically on page 187, you underneath appeals, fee for service claims, that's where you'll find the answer for that. On page 190, number 2, NODMAR, the purpose of the review is to ensure that the hospital issued notice of non-coverage or NODMAR is correct and that the patient is not being discharged prematurely from care. Number 4, what is the purpose of PROS? They review items or services provided to Medicare beneficiaries in order to determine the medical necessity.
Where in the book did you find that?
One moment.
Yeah, I couldn't find that either.
It's going to be after the NODMAR, after the NOMAR, I think underneath physician review of medical records. Because a quality review study can be defined as an assessment conducted by or for a peer review organization. So I think after that paragraph on page 190,
Yeah.
underneath physician review of medical records, right in there.
Okay, thanks.
Yep. All right, and then page 191, number 2, what is the best practice for reporting Medicare fraud? It is to be informed so you can recognize Medicare billing fraud. First, you have to know the rules, follow the procedures posted in your facility or in the facility's procedure manual. Additionally, there is a wealth of information on the internet, both on the CMS website and on the Medicare government website. On page 191, number 2, CLIA has no direct Medicare or Medicaid program responsibilities. The answer is true. All right, any questions in chapter 9?
No.
All right, let's move on to number 10. We'll start with page 200. All right, number 2. What are the regional contractors' responsibilities? To establish provider networks, operate TRICARE service centers, provide customer service call centers, provide administrative support with enrollment, care authorization, claims processing, and distribute educational information to beneficiaries and providers. Number 4, name the 3 main TRICARE coverage options: standard, extra, and prime. On page 205, number 2, into which option are active service members automatically enrolled? It would be prime. Number 4, list 2 supplemental TRICARE program options. Students should choose 2 of the supplemental programs from the text. You're either going to have TRICARE dental program, TRICARE Overseas Program, and TRICARE Young Adult Program. Number 6, who is eligible? It would be retired members of the reserve component who are in receipt of retirement pay, and Medicare eligible family members, Medicare eligible widows and widowers, certain former spouses and beneficiaries under 65 who are also entitled to Medicare Part A because of a disability or chronic renal disease. Over on the right-hand column, number 2, what color is an ADSM's card, a military retiree's card? It is basically, tan 1 is a dependent of an active duty member, red, retired reservist, not age 60, blue, retiree, and green, reserve ready. 4, why are Social Security numbers being with DBNs? And it is to protect beneficiaries' privacy. Okay, page 207. For page 207, number 2. The answer should be 15. Yes. Number 4 should be false.
False.
Page 209. Number 2 should be $1,000 as of 2013. Page 211, number 2 should be true. 4, express claims or easy TRICARE. And 6, you should have provider name, date of service, description of service, amount billed by the provider, Chapt VA allowed amount, amount not covered, amount paid by OHI, amount applied to the beneficiary's annual deductible requirement, beneficiary and family deductible accrual, Chapt VA payment, annual catastrophic cap accrual, and remarks. On page 219, number 2, what do you have for number 2, Kelsey?
You are the spouse or child of a veteran who has 100% rating for service-connected disability. And basically, page 211, those 4 bullet points on the right side.
Perfect. Okay. Number 4, Kylie, do you have the answer for number 4?
Actually, I didn't get that.
All right, that is actually the annual deductible and co-payment.
Okay.
Number 6 is false. And number 8, the answer is Medicare. Turn to 220. Number 2, where does the health insurance professional send Chapt VA claims? Kelsey?
The VA HAC Champa P.O. Box 65024 in Denver, Colorado.
Yes. All right, and then number 4, what is the deadline for filing Chapt VA claims? Kelly?
I have 1 year from the date of service, or 1 year
Yes.
from the date of discharge.
Yep. 1 year from the date of service. All right, 221, number 2, Kelsey,
True.
yes. And number 4, an appeal request to Chapt VA must contain the reason why the claim is being appealed, a copy of the EOB or determination letter, and any new and relevant information not previously considered. Let's turn to Chapter 11. Page 238. Who is eligible for work comp benefits? Kelsey?
An employee who is injured on the job or develops an employment-related illness that prevents the individual from working.
Yes. Okay, number 4, what is no-fault insurance? Kelly?
No-fault insurance is benefits that are paid to the injured or ill worker regardless of who is to blame for the accident or injury.
Yes, workers' comp is a no-fault insurance. Page 243. Number 2, what items should a typical claim request include? The claim request should include information about the employee provides, information the employer provides, the attending physician statement and authorization release form that enables the insurer to gather additional information as it becomes necessary. Number 4, what is the health insurance professional's role in the disability claims process? What do you have for that one, Kelsey?
I said it was the paragraph right to the left of it, the employer's responsibilities.
Right, to see that everything is possible done to facilitate the claims process for the benefit of the medical practice and the disabled patient. Okay, page 249. Number 2, how do federal programs define disability? As a significant difficulty with or the inability to perform certain day-to-day functions as a result of a health condition or impairment. Number 4, what is the difference between SSI and SSDI? What is SSI? Kelly?
SSI is a federally funded cash assistance to qualifying elderly and disabled poor individuals.
And SSDI? Kelsey?
Cash benefits to disabled workers younger than 65 and certain dependents who have lost their income because of disability.
Yes. And that's it. Any questions on these chapters, ladies?
No.
Actually, I did have one question. I'm sorry.
Don't be sorry.
Where did you find, on page 190, number 4, I got cut off. Where did you find about the pros? I could not find it anywhere.
What page again?
190, that question, number 4. What is the purpose of pros? Where did you find that? I couldn't find it anywhere.
That was on page 190 underneath the physician review of medical records. And underneath,
okay.
after the NODMAR.
After the no more. Okay.
in those paragraphs. We lost you when we answered that one.
Yeah, I know. So I just wanted to make sure so then I can go back and find it.
All right. So let's go on to chapter 12. So this is going to be a little different in that you don't have an ICD-9 book to use with this yet, and if you did and you used it, that's fine. Keep in mind that the Health Insurance Today book is not going to be on the national exam. Kelly, you want to mute your microphone, please?
Oh yes, sorry.
That's okay. So let's just start covering chapter 12 with diagnostic coding. So in diagnosis coding, this is the reason that you come into the office. This is why you're seeing the doctor. So it's up to us to understand the codes, because the codes are in turn used in all the healthcare entities, including the providers, your government health programs, your private health insurance companies, and your workers' compensation carriers. So what is a diagnosis? As I just explained, it is the reason that brought the patient to the healthcare facility. It can be taken as a final diagnosis after an exam. It can also be taken from a variety of sources within the medical record, but it must be determined by the healthcare professional who is providing the medical care. Not you, the CA, not you, the medical assistant, the physician. So there are three major coding structures. And you'll notice that with the ICD-9, it's the International Classification of Diseases, 9 meaning the 9th revision, and CM being the clinical modification. Volumes 1 and 2 are your diagnosis codes, and volume 3 are the procedure codes. So let's give you a little bit of history about diagnosis coding. ICD-1 was actually put to use in the 1900s. It was modified every 10 years except between ICD-9 and ICD-10. And your ICD-10 compliance is required as of October 1st, 2015. So your ICD system resulted from a group effort among your World Health Organization and 10 international centers, so that medical terms reported on, death certificates by physicians, medical examiners, and coroners could be grouped together for statistical purposes. So the purpose of this system is to promote a way of comparing the collection, classification, processing, and presentation of death statistics. The coding of your healthcare data allows access to health records according to the diagnoses and the procedures for use in clinical care, research, and education. And you have a list on page 254 and 255 in your textbook that provides some other common uses of codes in healthcare. You'll see the table on page 255 to the right, comparisons of diagnosis code sets. And it tells you what ICD-9 is going to be versus ICD-10. And then to compare the formats even further, you'll see underneath on table 12-3 the comparison of the formats. So let's talk about the ICD-9 coding manual just for a minute. There are 3 volumes available in a single book, and most of your publishers will combine volumes 1 and 2 in a separate manual. Typically, insurance companies do not require the use of volume 3 because this is for physician and outpatient billing. However, your volume 3 is still used for hospital inpatient coding. So it will be important for you to note the format of the ICD-9 differing from one publisher to the next concerning how the material is arranged. But keep in mind that the basic information is the same. Volume 2 is your alphabetic list or alphabetic index. While this is the starting point for the coding process, a diagnosis should never be coded strictly from the alphabetic list. After the diagnosis has been abstracted from the patient's health record, the alphabetic list is used to guide the coder to the appropriate page in Volume 1, where codes are arranged in numeric order. So it's a numeric list that the exact code can be determined. Your code structure consists of 3 to 5 characters based on which code best represents the patient's diagnosis. So in the diagnostic coding system, the codes are broken down into the 3-digit category, which is sometimes called a rubric. ICD-9 codes identify symptoms, conditions, problems, complaints, any other reasons for procedure, service, or supply provided. So it's going to be crucial for you to know that the diagnosis is coded to the highest level of specificity. And you're going to do this by consulting your alphabetic list first. The health insurance professional will then determine more accurately which 3-digit code is sufficient to describe the diagnosis. And then your diagnoses are coded. You'll find out if they're inadequate or inappropriate. And if that's the case, be careful because they may result in a claim being underpaid, overpaid, delayed, or denied. So volume 2 on page 257. So volume 2, section 1, index to diseases and injuries. This is the largest section. It's the index to diseases and injuries. It is organized alphabetically by the main terms, which are always printed in boldface type. You'll notice that in the Buck book, they are in red type for easy reference. So when we get to the Buck book, you'll see that. All right, you'll notice in your books, you have on page 258, figure 12-2 at the bottom of the page. You'll see that many conditions can be found in more than one place in the alphabetic index, which can be confusing. So for example, obstetric conditions may be found under the name of the condition and under entries for delivery, pregnancy. Complications of medical and surgical care are indexed under the name of the condition and under complications. Eponyms such as Vincent's over on the top right-hand page. Medical eponyms are adjectives. Sometimes the name of the person who first discovered the disease or used the instrument used to describe the specific operation, the surgical instrument, the diseases and parts of the anatomy. In your ICD-9 CM index, eponyms are listed as main terms in your alphabetic sequence and under the main term for disease, syndrome, and disorder. you'll notice that there's a description of the disease or syndrome usually included in parentheses following the eponym. Can you name at least 4 eponyms? Kelsey, can you name 4?
Vincent's, Eisenbert's, Vincent Plummer, and Virtuos.
Yep. Okay, essential modifiers, figure 12-4. Your essential modifiers are main terms that are followed by a list of subterms. These are called your modifiers, which will affect the selection of an appropriate code for a given diagnosis. Your essential modifiers are indented under the main term and arranged in alphabetic order. They describe the essential differences in site, cause, or clinical type. Your modifiers help you select the appropriate diagnostic code and may describe various body sites, etiologies, or clinical types. When you're selecting a code, make sure you review the modifiers listed to determine the specific code that you should assign. Your non-essential modifiers, these are main terms that they may also be followed by a series of terms in parentheses. These terms are non-essential modifiers. When you are assigning a code, the presence or absence of these parenthetical terms in the diagnosis has no effect upon selection of the code listed for the main term. Conventions for Volume 2. Turn the page. Conventions for Volume 2. This is where you have parentheses. Your non-essential modifiers are enclosed in these parentheses. You also have C, which is a cross-reference directing the coder to look elsewhere for the appropriate code. Now, everything we're learning in this chapter tonight is going to be a repeat when we get to the Buck book. The same with some of the E&M codes. C also is a cross-reference directing the coder to locate the main term because adequate information cannot be located under the first main term. Kelly, can you just turn your volume down a little bit or mute your microphone? There's a lot of reverb.
Oh, I must have.
Thank you. So cross-reference notes such as C, C also, C condition, and C category refer the coder to continue searching under another main term. Some other conventions you'll find are used in the alphabetic index might include note, which defines terms and provides coding instructions, omit code, which directs the coder not to assign a code for that particular condition, and NEC, not elsewhere classifiable, which means that ICD-9 does not have a code that describes the condition. Your hypertension and neoplasm table, these will also be in the alphabetic index, but they are their own tables. And you will see that when you have your ICD-9 book and we talk about tabbing and going through those books. Sections 2 and 3 in your books will be a table of drugs and chemicals, an alphabetic index to external causes, national coverage determination and local coverage determinations. These are national and local Medicare standards. Process of classifying diseases on page 261. The first thing that we do as a coder is that we must locate the diagnosis in the health record. This can be straightforward sometimes, but many times the encounter form more frequently uses diagnoses within a certain medical specialty along with their corresponding ICD-9 codes. Other times, the coder may have to refer to the clinical notes to locate the diagnosis. If the notes are handwritten, deciphering the healthcare professional's handwriting sometimes can be challenging. Your process of clarifying the disease, you want to pay attention to your notes. Over on page 263, let's look at the top figure 12-10. Never code from the alphabetic index. All right. You want to make a note here that 611.72 following breasts, shown in the portion of volume 2 here, this is a 5-digit diagnosis code for a breast mass. The number one cardinal rule in coding is never to code from the alphabetic index alone. Before you would assign this code, it's important to remember and read any special notes or instructions, after which the health insurance professional, us, the coder, would turn to volume 1 in the tabular index and locate the code and confirm that is in fact the code to be using. Volume 1, the tabular list. There are 3 types of codes in volume 1 of the tabular list, page 264. There is the 3-digit category code, the 4-digit subcategory code, and the 5-digit subclassification code. We will get into this more in the Buck book. There are also 3 types of codes. The 3 types of codes. To clarify further the 4- and 5-digit necessity, let's say that the patient's diagnosis in the health record is coronary atherosclerosis. If we were to look up the 414 code in the tabular list, we would note that there is a bullet next to it, a little color-coded bullet, which tells us that we need to code to another level. All right. If you look on page 265, you'll see your symbols right there. There are also supplementary sections of volume 1. This would be your V codes. Your V codes are used when circumstances other than a disease or injury is classifiable. So someone who is not currently sick, but they visit the medical facility for a specific purpose, maybe chemotherapy, or when a birth status of a newborn is reported. These are when we would use V codes. E codes, these provide a classification of external causes. I'm not going to go into locating a code yet. All right, let's turn to page 266 and talk about special coding situations. Coding signs and symptoms. If a patient's condition has not been specifically diagnosed, the health insurance professional must code the signs or symptoms. When we see phrases such as rule out, questionable, suspected, or probable, these are not coded. Okay? They would not be coded. Some common examples of signs and symptoms might be dizziness, fever, nausea, shortness of breath, headache. Etiology and manifestation coding. You want to code first the underlying condition and then the manifestation. Your combination codes. Over on page 268, your combination codes. A single combination code used to classify two diagnoses, or a diagnosis with an associated secondary process, or a diagnosis with an associated complication. Coding late effects. What is a late effect? A late effect is called a sequela. This is a residual effect after the acute phase of an illness or injury that has been terminated. There's no time limit on when a late effect code can be used. Coding neoplasms. A neoplasm results when we have abnormal cells that grow uncontrollably, usually resulting in a tumor. We're going to get into all of this again in your buck book, so don't worry about memorizing it or having a firm grasp on it right now. We're going to go over this again in the buck book. Coding hypertension. You would locate the main term in the alphabetic index. It would be hypertension. There is also a table for hypertension in your book. ICD-10, we're going to go over that as well. ICD-10 basically was implemented by WHO in 1993 to replace ICD-9. That's over 10 years ago, right? Long time. So ICD-10 is used in almost every country in the world except the US. CMS is recommending that medical practices continue to prepare for the implementation of the new code set. You need to make sure you have new software, hardware, be testing, all kinds of stuff. You're going to see two major coding systems of ICD-10. The International Classification of Diseases for outpatient as well as inpatient. You're going to see a lot of improvements. ICD-9 has 13,600 codes, whereas ICD-10 has nearly 70,000 codes. So again, if you got into this field thinking you were going to have to memorize stuff, you're wrong. This is not about memorization. This is about knowing where to find the information. Process of classifying diseases, page 270. We would first locate the diagnosis in the health record. We might find it on the encounter forms or the clinical notes that may be handwritten. We want to identify the main term within the diagnosis. ICD-10 overview, there's two parts. Again, ICD-10 is outpatient. ICD-10 PCS is inpatient. The code structure set on page 272, you'll see in table 12-4. That's a really good example of the code structure of ICD-10. The first three digits will be the category. The next two will be the etiology or the anatomic site. And then category, etiology, and extension. So it could be 7 characters. You're going to look up the code in ICD-10 the same way you do in ICD-9. You're going to start in the alphabetic index. They give you an example of what an alphabetic index looks like here in the book on page 274. You have main terms right underneath figure 12-20. You have your essential and non-essential modifiers. You also have conventions in ICD-10 as well. So the coding steps are no different in ICD-10 than they are in ICD-9. The format and structure is very similar. You have conventions that are similar, punctuation that is similar, your instructional notes, the manifestation in etiology. You have guidelines in ICD-10 the same way you have guidelines in ICD-9. Section 4 is where you find all of your outpatient services. And the same kind of coding features, combination codes, late effects, impending or threatened, and laterality. There's also a table of drugs and chemicals, your E codes, your V codes, your combination codes. How do you find it in the tabular? Well, you look for it in the alphabetic index first. All right. So I did say that in class we would try and do a few things from page 277. And I just wanted to show you, so I'm going to share my screen. Hopefully you can see it. All right. So I'm not sure how big you can see this when it comes on, okay? You're going to have to tell me. All right. So you should be able to see that I have Google up, right?
Yeah.
All right. So as we move on into the future in this class, I'm going to encourage you to use Google to help with defining some terminology or help you to find your answers, all right? You're going to be using the alphabetic index, but if you're not sure what a word means and you can't find it in your terminology book, come here to Google and Google it. So we're going to look up pressure ulcer of right elbow. Well, we can type in pressure ulcer of right elbow, but what we really want to know is ICD-9 code. So we would put ICD-9 code for pressure ulcer of right elbow, all right? And it comes up with ICD-9 data. There's also find a code. There's cms.gov. Let's just pick the first one for right now. And it gives us the ICD-9 data. There's also find a code. When you get into the Buck book will even give you resources to go and find codes. But really what you're looking for is pressure ulcer elbow. It tells you ICD-9 code 707.01. It will be replaced in the future by the ICD-10 code equivalent. It tells you when that will take place. But at the very top, it's telling you that ICD-9 diagnosis code for pressure ulcer of elbow falls under diseases of the skin and subcutaneous, other diseases of skin and subcutaneous, and chronic ulcer of skin. So it is already giving you what I call the drill down. So if you were looking for this in your ICD-9 book, this would kind of be the flow that you would follow. You would start in the alphabetic index, look up pressure ulcer, go to elbow, and there will be different ways that we'll be able to find it. There might be always more than one way. But this way you can see the disease synonyms ulcer of elbow, the different stages, the left elbow, the right elbow. And then when you scroll down, you'll see here that it gives you ICD-9 Volume 2 Index, entries containing back references to 707.01, decubitus ulcer, see also pressure, ulcer pressure, elbow is 707.01. So very similar to what we would find in our ICD-9 book. Then you would have to go into the tabular and find out if that truly is the correct code you would want. So for some of this homework, you could actually just use Google and find it. But in the real world, what I would say to you is don't always rely on just this. Okay, make sure you're always confirming it in your tabular. Okay?
Yeah.
So we could easily choose 707.01, I think it was. Yes, for elbow. Pressure ulcer of right elbow. Now, in ICD-10, what's going to happen is that we will be able to choose a diagnosis code that will specifically say right or left elbow. And I think if we go back, it actually allows us to, no, it doesn't. It will give us synonyms like pressure ulcer of left elbow, right elbow, but the diagnosis code itself does not specify. We would have to indicate that in our notes at the time, our documentation, and probably have to attach those notes to the claim if they wanted more information. Okay? So that one would be 707.01. All right, let's try diffuse interstitial keratosis. So I'm going to put ICD-9 first. ICD-9 code for interstitial keratitis.
So is it right now that you're still using ICD-9 and then this October it switches?
Yes.
Okay.
And we can't just jump into ICD-10. We have to have an ICD-9 foundation before we can even get into ICD-10.
Yeah.
It's going to be required. Because you have to learn the foundation first. So for interstitial keratitis, they're coming up with 37050. So again, we would take that code and go into our tabular and see if that was the appropriate code. But for homework's sake, we can say that this is the correct code to use, 37050. All right, let's go back. ICD-9 code for eustachian.
So what would you do if the Google code didn't match the tabular code?
Then we have some research to do. Because you're not going to have 100% accuracy with Google. Just because everything is as good as the people who put it in, right?
Yeah.
Just like we have mistakes in our book, okay? With all the assignments even, occasionally I'll find some that are wrong even in the book. And I'll have students say to me, well, then how can I trust my book? We can't, honestly. Think about how many codes are in these books. Someone had to actually sit and do the research to compile the book. It didn't just happen by itself. So for eustachian tube obstruction, it could be a dysfunction of the eustachian tube, which could easily be 381.81. The disease synonyms say bilateral eustachian tube dysfunction, dysfunction of eustachian tube dysfunction. So again, you would take the code. We could drill down on it because it allows us to click on the code and see if it takes us any further. So for homework's sake, this was probably the easiest way to be able to have you ladies be able to do your homework.
Yeah.
Because you don't have your ICD-9 books yet, or if you did, you can still use your ICD-9 books. But I don't think everyone has them. Do you have yours?
I'm looking. No. It's
Okay.
not one of the 6 that we already have.
It should say 2015 ICD-9 book. It might be a small gray
Oh,
book
yeah.
or a big
It is.
spiral. Okay. So go to the alphabet index and look up dysfunction.
I feel like an idiot. Is it DY or DI?
DY.
Okay, that's what I thought.
It's okay. It's been a long day.
So, dysfunction, and then I would go to the eustachian tube.
Yes.
381.81.
Perfect.
So it's
Now
right.
go to your tabular.
And which one's the tabular?
It's in the same book, but it's going to be in the 381. Keep going. You were in the right spot. There you go. Fan the pages and look for 381. Keep
Oh, I
going.
see. (381) non-supportive otitis media and eustachian tube disorders.
There you go. You just looked up your first code.
Wow.
Woohoo!
I guess it's not as crazy as you would think it is.
Nope. No, what's going to come later on for you is really knowing where to start in the alphabetic index. And
Yeah.
that's what we're going to learn as we go through the chapters in the Buck book. Again, this Health Insurance Today book is all about the billing side. And they touch upon the diagnostic coding in here and the HCPCS coding and that type of stuff. When we get into the Buck book, that's when we're getting into the meat of the actual coding. All right, and you'll be learning more about really how to find it, what to look up, and that kind of stuff. But for tonight, I just wanted to give you a little taste of this is really what it's like. So I'm not going to go over any more of this chapter. I think we've covered enough for now.
Okay.
because we're going to get into, as I said, the bulk of it in the Buck book. Do you have any questions around this chapter?
No, I mean, I actually feel a lot better now that I've used that big book.
Okay. And when we get into that book, we're going to talk about tabbing. I'll
Okay.
have to buy tabs. Okay. All right. Chapter 13. Chapter 13 is all about the procedural E&M and HCPC coding. So this is about the CPT book. Do you have your CPT book? That should look like your ICD-9 book.
Yep.
Okay? So we will go over how to tab that also. Give me just a minute.
There's actually tabs already in here.
Yes, and we'll talk about how to use those. All right, so some people have this as an ICD-9 book.
Yeah.
All right. Some people have this as their HCPC book. Some have this as their ICD-9 book. And you'll see the tabbing that I've done.
Mm-hmm.
And the same thing with the CPT book. We'll go into that more in depth when we start working with them in the Buck book.
Okay.
And I have pictures of them also. So then for chapter 13, we will probably just go through that one. We probably won't spend a lot of time going through that one only because it is the CPT as well. And we'll be covering that in more depth also. But let's just go over some of the, because it doesn't hurt to hear it again later on as well. With your CPT book, these are codes where the numbers are assigned to every task that the medical practitioner may perform and every service they may provide to a patient, including medical, surgical, and diagnostic services. They are then used by the insurers to determine the amount of reimbursement that a practitioner will receive from an insurer. So the purpose for your CPT codes is uniformity, to provide a uniform language that accurately describes those types of services, whether they be medical, surgical, or diagnostic, that provides a reliable nationwide communication among those physicians, insurance carriers, and patients. The first edition is primarily containing the surgical procedures. And then you have limited sections throughout the book on medicine, radiology, laboratory procedures, And then some of the later editions expand the systems of terms and codes. You'll see that there are 3 levels of procedural coding. Level 1 will be the AMA CPT 5-digit codes. These are used for reporting services performed by the healthcare professionals. Level 2 are your HCPCS and National Medicare codes. These are used to report the medical services, your supplies, drugs, and durable medical equipment. And then level 3 codes are descriptors are developed and used by local Medicare contractors. However, some of those codes are no longer used. So it's just paying attention to the books and what's been deleted and what has been revised. The actual manual format is very similar to your ICD-9 and ICD-10 book in that it is made up of several parts. It begins with an introduction, and then it's identified by lowercase Roman numerals. There are 5-digit procedure codes. They are listed as procedures and services along with the 5-digit codes. They are presented in a numeric order except for your E&M section. Since your E&M codes are used by most physicians for reporting key categories of their services, the section is presented first. Your 5-digit CPT codes may be further defined by modifiers to help explain an unusual circumstance associated with a service or procedure. Using correct coding modifiers is crucial to getting claims paid promptly and for the correct amount. So each main section of the CPT is preceded by guidelines specific to that section. Your Category 2 codes, these provide a method for reporting performance measures. These are intended to facilitate the collection of information about the quality of care delivered by numerous coding services or test results that support performance measures. And also in your Category 2 codes, there are 6 sections that follow listing the main body of the CPT manual. There is also a list of Category 3 codes. This has not been proposed and accepted into the main body of the CPT book. You have appendices in the CPT. You have modifiers, summary of additions, clinical examples, summary of add-on codes, summary of exempt codes. And then you have other appendices as well. You start in the main terms, just like you do in the ICD-9 book. There are 4 primary classes of main terms. You'll see procedure or service, organ or anatomic, condition, and synonyms, eponyms, or other abbreviations. You will also have modifying terms in here, or subterms. You have code ranges. You will have single codes, multiple codes, and range of codes. You'll see in figure 13-2 some of the symbols that are used in the CPT book. You have the same thing, the bullet, the triangle on page 301. Modifiers. These will indicate the unique circumstances. They're not universal, so some only can be used with E&M codes. You will also have the unlisted procedure or service codes. They may be performed by physicians or other healthcare providers that are not represented by a specific category code. You will have special reports, items that should be addressed, definition or description of the service or procedure. It goes into a list of some other things that might need a report. As in the ICD-9 book, you will also see in the CPT book 2 types of codes, standalone and indented. You'll have conventions, punctuation, and symbols. What is the importance of the semicolon? It is used to separate the main term and the subordinate clauses in the code descriptions. It's also used to save space in the manual. You also have codes in the tabular that are formatted for 4 classifications: section, subsection, subheading, and category. You have the cross-reference with C. It is the same as in ICD-9. It's a cross-reference. Basic steps for finding a CPT code is similar to what we do in ICD-9. Identify the procedure, the service, or the supply. Determine the main term, and locate the main term in the alphabetic index and note the code. Use your cross-reference. Read and follow the special notes and instructions, and then determine and assign the appropriate code. With your E&M coding, these are going to be codes from 99201 through 99499. These are at the beginning of your CPT book. This is what the provider does during the time that they are with the patient, not the amount of time spent. So the categories here will be your office visits, your hospital visits, and your consultations. Some of the vocabulary used in E&M coding on page 304 will be new patient. What is a new patient? A new patient is an individual who has not received any professional services from that physician or another physician of the same specialty within the past 3 years. An established patient is someone who has been seen in that facility by that provider or someone of the same specialty within the past 3 years. Outpatient is someone who has not been officially admitted to the hospital. An inpatient is who has formally been admitted to the hospital. A consultation is when the attending healthcare provider recommends that the patient see another physician, often a specialist. Do not confuse this with a referral. Some other terminology: counseling, concurrent care, critical care, and emergency care. There are documentation requirements. Your medical record is a valid source of proof here. Coding your E&M services should be based on the extent of the medical record, the documentation in that medical record. Some of the factors that you want to consider, page 306, the place of service. So where did it take place? The type of service performed, and whether the patient is new or established. Some of your place of service factors would be the physician office, the hospital, the emergency department, the nursing home, and any other place. Some types of service would be your office visit, the consultation, the admission, and newborn care. Some patient status factors: new patient, established patient, outpatient, and inpatient. We have key components to our E&M codes. I'm not going to go over these tonight. We're going to go into depth when we hit chapter 15 in the Buck book about E&Ms.
Okay.
So let's move on to some subheadings of the main E&M section on page 309. Office or other outpatient services would be the first subheading. This is where professional services are actually rendered within the physician office in an outpatient or other ambulatory facility. Then we have observation services and hospital inpatient services. We also have consultations, emergency department, critical care services, and nursing facility services. We also have some E&M modifiers, so you would want to make sure that you check for any potential modifiers, because denial of payment may result if modifiers are left off. The importance of documentation. Proper documentation helps to basically tell the payer why the patient is here. It establishes medical necessity. It gives pertinent facts and findings, observations. It helps us to accurately and timely file these claims and get reimbursed. Some billing and coding errors. Well, no documentation for the services billed, that would be an error. No signature or authentication of documentation is another one. Over on page 314, top left-hand column, billing and coding errors. We also have the E&M documentation guidelines, 1995 and 1997. These are two specific guidelines, both applicable in their own right and still used today. The HCPC overview, we have 3 levels, level 1, level 2, and level 3. Level 1 are your CPT codes, 2 are your national codes, and level 3 are your local codes, which formerly some have been deleted. We also have modifiers in the HCPC book. We have main terms. Again, all 3 of these books, we will be looking up things very similarly. We will start with the main term and then move into the tabular. Each book has its own set of indices. What you will find in all 3 books is that it has its own set of modifiers. So we will be tabbing those sections. On page 317, the NCCI is the National Correct Coding Initiative. It serves 2 purposes: to ensure that the most comprehensive group of codes are billed rather than the component parts, and to edit 2 codes that cannot reasonably be performed together on the basis of either the definition or anatomical considerations. HIPAA and HCPC coding. With the advent of HIPAA, CMS has required medical offices to eliminate any unapproved local procedure and or modifier codes that they are currently using. A crosswalk is a procedure by which codes used for data in a database are translated into codes of another database. And then in coding, a crosswalk is a link that refers to a relationship between the medical procedure and the diagnosis code. They actually are talking about a CPT 5, which is intended to improve upon CPT 4 coding. It is not yet implemented nationwide. There is no current date set, and it would still be 5-digit codes. Any questions in this chapter?
No, not yet anyway.
Okay. I think once we get into it in the Buck book, it will make a little bit more sense. It just doesn't make sense to go over it a lot tonight, just because the 2 courses are combined. If it was a course all by itself, then I would go into it in more detail. But because we will be covering it again later on, I will go into more depth at that time.
Okay.
Why don't we take a few minutes quickly right here and come right back and finish up, okay?
All right. Yeah, I mentioned it to them, and I think a couple of them are coming back in for it.
view and show markups? Yeah. You can take off. The one up above it says simple markup, and you can choose no markup. Did you find it?
Dish ice cream. Bye.
All right, can you hear me?
Yeah. Yeah.
Excellent. Chapter 14, the patient. All right. When it comes to patients visiting a medical facility, we bring with us, or they bring with them, certain expectations that are influenced by previous experiences that they've had with other healthcare providers, the media, and opinions of friends and family. If the other healthcare provider and office staff members are oblivious to these expectations, the entire practice risks being perceived as cold and unfeeling. So good patient-provider relationships result when these expectations are met. So how do we meet those expectations? It's our responsibility as staff, whether we are front office or back office, to find out what the patient's expectations are by asking questions. So if we walk into a shabby reception room, that is going to suggest that they are getting shabby care. Besides being brief and high quality, paperwork should seem relevant to the reason that the patient is there. What are some of the other factors that might affect patient expectations? Well, professional office setting, honoring appointment times, patient load. Time is a valuable commodity, and staying on schedule communicates respect for the patient's time. Time management experts recommend that the medical receptionist explain approximately how long an initial visit will take and what to expect. Some experts suggest scheduling new patients during a time when the practice is busiest, as a new patient often draws conclusions about the competency of the healthcare provider by observing how many others are waiting in that reception area. Sharing some personal information promotes a good patient-provider relationship and often tends to relieve patient anxiety. Privacy and confidentiality. When we make and receive telephone calls, we want to speak quietly and close the glass partition if there is one. Those are recommended by HIPAA but not enforced. Conversations among staff members and between staff members and patients should not be loud enough to be overheard. Financial issues. Experts say it is good practice to discuss finances early on in the patient encounter, maybe as early as when the patient phones in for an appointment. Because our patients today expect the cost of their health care to be addressed up front. Some of the future trends in healthcare. Well, we want to prepare for an increasing volume of elderly patients as our baby boomers are aging. We would anticipate that they are the new type of patient, one who is going to take charge of their own health care through the use of the internet. And a lot of today's patients are being referred to as consumers who want and expect more choices in their health care. We do have certain HIPAA requirements on page 327. HIPAA has had a big impact on healthcare, particularly where confidentiality is concerned. The release of any information contained in a patient's health record to a third party, with certain exceptions, without a signed release of information is prohibited by law. HIPAA's privacy regulations allow the release of information without a written authorization from the patient for the purposes of billing and/or claim submission. Usually when you go into a provider's office, they have you sign something up front, and that addresses the issue that you don't have to sign something every single time you go in. A major component of the HIPAA is a nationwide federal standard concerning the privacy of health information and how it can be used and disclosed, which applies to covered entities. PHI, or Protected Health Information, over on page 328.
Somebody switch it?
I'm sorry, we're still on page 327, right-hand column. Under HIPAA, PHI is referred to as individually identifiable health information, identifiable medical information, which includes the medical records, the medical billing records, any clinical or research databases, tissue bank samples. The covered entities generally will not be able to communicate or transfer PHI to non-covered entities. HIPAA requirements for covered entities. This is where the HIPAA transaction 5010 comes in. This is a level 1 compliance, and the proposed changes to the CMS 1500 form. The patient's rights of access and correction on page 328. Every patient has a right to inspect or obtain copies of his or her PHI from the healthcare provider or health plan, but not from a clearinghouse. There are exceptions to the right of access, which are very limited. There is a federal rule proposed by the Department of Health and Human Services that in 2011 required hospitals, physician offices, and insurance companies to advise a patient, if requested, of anyone who has accessed the patient's electronic medical record. Patient's rights. Patient has a right to request corrections or amendments to his or her medical record and to place an explanation into the record if that request is denied. Incorrect information should be labeled as corrected and the correction appended. Accessing information through patient authorization. You'll see in this textbook there's an example of a HIPAA approved release of information form on page 330. And that's a pretty good HIPAA compliant release of information. Covered entities can release de-identified health information without patient authorization. To release information without patient authorization, the covered entity cannot have actual knowledge that the information could be used alone or in combination with other information to identify that individual. To de-identify health information, you're basically blacking out any identification for that patient.
If you have a chance, we have ice cream sundaes out here to make.
Oh, okay. Thanks.
Billing policies and procedures on page 331. Medical facilities are in business to make a profit. Therefore, procedures and policies should be in place to protect the financial success of the practice. Patients should be informed verbally or in writing exactly what is expected of them as far as payment of fees is concerned. Assignment of benefits. This is where on many patient information forms, in addition to the authorization to release information, you will have verbiage above the patient's signature that will provide for the assignment of benefits, authorizing the transfer of payment from the insured to the healthcare provider, and sometimes even the assignment of benefits as a separate document. Keeping the patients informed. Discussing professional fees with the patients is an important step that requires a sensitive and balanced approach by the health insurance professional. When we have written information available, it can be helpful in collecting fees. The ultimate goal of healthcare office billing is reimbursement or payment for the medical services provided to patients, and the receptionist should request payment on the day of the visit, either before or after the encounter is concluded. Some accounting methods. Well, if the system is computerized, patient accounting system is not used. You would use the health insurance, paper accounting records, only if there were not any electronic records. A daily journal is considered a chronological record of all those patients' transactions. A disbursement journal lists all of the expenses paid out to vendors. General journal is just the most basic one. It's chronological listing of transactions. The general ledger is often the practice's financial records, and a patient ledger is a chronological accounting of the activities of a particular patient or family. You've heard of the OneWrite or pegboard accounting system. That is really just a manual, handwritten system that is used. It's less frequently used now. You will see that more electronic patient accounting software is being used. It begins with inputting the demographic patient information in, creating the patient account within the program, entering all of the patient data into the system, scanning in documents, completing paperwork, and then making sure you have a dependable backup, and those should be done daily. EMRs, also refer to electronic health records. This is what stores a patient's health history and medical information in electronic format rather than on paper. Billing and collection. Medical practices that maintain a high collection ratio say that the most effective way to do this is to establish a formal financial policy that is clear to patients as well as medical staff and enforce it. Page 337 in your textbook actually provides a list of suggestions that some healthcare providers use to aid in their financial success. Billing cycles are sending statements to patients on a regular basis in order to maintain cash flow and generate an acceptable collection ratio. Arranging credit or payment plans. Many of your healthcare facilities offer financial plans. Some patients do not have adequate insurance coverage or none at all, so they will make arrangements to be self-pay patients. Ideally, you want to establish a credit plan up front, or a plan up front that shows that they can pay, and what are they willing to pay and on what type of basis, regular basis. Establishing credit. The Federal Truth in Lending Act of 1968 has 4 conditions. When patients cannot make payments in full, credit is sometimes arranged and payment plans established. Problem patients, there should be a policy in place for problem patients, such as these, or for patients who, for whatever reason, send up a red flag. There are laws affecting credit collection, and these acts are discussed here on page 339 in your textbook. There are collection methods over on page 340, 2 common methods: collection by telephone and collection by letter. The collection call is considered far more effective than sending a letter. Billing services. Some healthcare practices outsource their medical billing by hiring a separate professional medical billing service, which can provide multiple functions for the practices. Collection agencies. Some experts suggest that delinquent bills should be turned over for collection only when it's obvious that payment made by any other means is a dead issue. Small claims litigation. Before making the decision to take a delinquent patient to a small claims court, the cost should be weighed against the monetary gain. And then small claims process. Plaintiffs fill out standard forms. The procedure starts with the plaintiff. Then the form outlines the detail about the claim and the various parties, what information is included. The small claims litigation can be successful, but it can be time consuming and costly. So just weigh your pros and cons about when you're going to the small claims process, is it really worth it versus going to a debt collection agency. All right, any questions?
No.
All right, then let's do chapter 15. All right, chapter 15 is all about the keys to successful claims management. All right, on page 346, 347, there are 2 methods for submitting claims. One is paper and one is electronic. And some providers still use the CMS 1500 form. Most of your claim forms can be submitted electronically to all of your payers. And if you are doing that, the provider's office must be using a computer with software that meets the electronic filing requirements that were established by HIPAA and the claim standards and CMS. There are limited exceptions to this mandate, so be aware of those before you start sending claims or set things up. There are general guidelines to completing a CMS 1500 form. You will notice on page 348, they list the general guidelines for you. There are also instructions provided on Evolve as well. So there's 6 simple keys to success for submitting claims. And you'll see on figure 15-1 on page 349 that we start out with the first key. And the very first key is collecting and verifying patient information. Updating that patient information regularly or annually is a good policy. Be sure to also verify the patient's insurance coverage. The second key is to obtain necessary pre-authorization and pre-certification. Your services that most often require these would be your inpatient hospitalizations, new or experimental procedures, and certain diagnostic studies. The third key is documentation. It is the provider's responsibility to document appropriate comments in the patient's health record, which would include the history, the physical exam, and the medical decision making for that patient. They also need to fill out the encounter form. The fourth key is to follow payer guidelines. And the fifth key is to proofread claim to avoid errors. And you'll see box 15-2 on page 351 will provide you with a list of common errors that are made on your claim forms. The sixth key is to submit a clean claim. And that is by ensuring that all of the information necessary for processing the claim has been entered on the claim form and the information is correct. All right, so HIPAA's requirement for employer identification, which is an EIN number. Health plans accept the EIN on all of their electronic transactions that require an employer identifier. Clearinghouses use the EIN on all electronic transactions that require an employer identifier. Your healthcare provider uses the EIN on all transactions wherever required that are electronically transmitted. And employers disclose their EIN when requested to do so by an entity that conducts standard electronic transactions that would require those EINs. So what is the claims process? Let's take a look on page 353. When a claim error is discovered that could result in, let's say, a denied claim or corrected claim, we could get no reimbursement at all, or we would have to send it back and mark it as corrected billing. So step one is where the claim is received. Then we have the healthcare practice that we should have something in place that tracks the claims. So if we're filing paper claims, there should be some sort of tracking system, such as a suspension file. The alternative to the suspension file is to record claims on a claim register log. Then we have where the insurer sends the payment for services in the EOB, which is also called the remit, and it gets sent back to the provider's office. Then once we get that EOB, we have to interpret it and know how much was paid, what was not, and why. In other words, we need to know how the claim was adjudicated. So we should know how to read that EOB because it helps in collecting reimbursement, including any balance owed by that patient. And then we post the payments. All right, on page 358, you'll see an example of an EOB, what it looks like. when you get it in the mail. On page 359, we talk about downcoding. What is downcoding? This is often where the healthcare practice does not agree with the choice because the substituted code results in a lesser payment. You'll see similar problems occurring when an insurer's payment system is based on CPT codes and a relative value scale code is submitted that does not directly translate to CPT. If your claims adjuster changes a valid procedure code that was submitted on the claim, the health insurance professional should contact the claim adjuster and ask for the reason. Time limits. Not all of your payers deny late claims, but instead they levy a fine or penalty because of lateness or past timely filing status. Most of your insurance companies above also have a time limit for filing appeals, which varies from carrier to carrier. Your health insurance professional should establish a routine for completing and submitting insurance claims. To process secondary claims on page 361, this is a person who has dual coverage. And so when they have dual coverage, there has to be a COB, a coordination of benefits. So this is where a patient is covered under two plans. That patient that I mentioned earlier that has Medicare primary, Medicare secondary, not primary. So someone might have Medicare primary, Anthem secondary, or Anthem primary and Cigna secondary. It just depends because one spouse might be covered by one plan and the other spouse the other plan, and they can actually be on each other's plan, so they have dual coverage. The insurer who is obligated to pay first is the primary payer. That is the payer that receives the claim first. The insurer who pays after the primary carrier is referred to as the secondary payer. Your secondary carrier will receive the claim after the primary carrier pays its monetary obligations. Some of your secondary payers receive an automatic crossover from primary to secondary payer. Your coordination of benefits. What is meant by a coordination of benefits?
Is that kind of what you just said?
Yeah, exactly. The birthday rule. The birthday rule is the payer whose subscriber has the earlier birthday in the calendar year. That will generally be the primary. So the rule of thumb for dependent children is that covered under more than one policy. So if my husband has a policy and I have a policy, our children will actually be covered under his policy primary because his birthday is earlier. MSP, Medicare secondary payer. Okay, so Medicare secondary payer In the instance of dual coverage with Medicare and Medicaid, there is usually an automatic crossover and the second claim is not needed. The important reminder here is that the health insurance professional, we should check the current guidelines of the specific payer in question when a secondary policy is involved. Medicare automatically crosses claims over to most Medicare supplement policies, but you want to make sure first, do not just assume. And you can find out by calling Medicare to ask them. Optimizing billing and claims processing. One of the major problems that healthcare facilities have always faced is the ability to maintain a satisfactory charge to collection ratio. So if you look at page 362 in your textbook, there are tips in here on how to improve your office efficiency and increase revenue. We have the real-time claims adjudication. This is a means of electronic communication that allows instant adjudication of an insurance claim, including the third-party insurer's payment, adjustment, and patient responsibility. This typically will reduce the time frame of claims submission to adjudication from the traditional 2 to 6 weeks to just a few seconds. The appeals process on page 363, who can appeal rejected or underpaid claim adjudication? In many instances, providers of service and patients have the right to appeal a rejected insurance claim or a payment made that the provider or patient believes is incorrect. Before appealing a payment or claim, whether it's with Medicare or a private commercial insurer, the health insurance professional should notify the insurer in writing that there has been an error. If the health insurance professional believes a claim has been wrongly denied, an appeal can be filed. If the appeal process differs from carrier to carrier, however, appeals generally must be in writing and initiated within a specific number of days, usually 30 to 60. Your appeal letter should identify the claim and the reason of the health insurance professional believing the claim should be approved. Your outcome of the appeal is then determined. The provider is notified verbally or in writing of the decision, and the decision is usually final. However, some of your carriers allow second level or third level appeals. When you are appealing a Medicare claim, your providers and suppliers who do not accept assignment on claims typically have limited appeal rights. And there is a whole procedure from Medicare on how to appeal a Medicare claim. So definitely some websites to explore at the end of the chapter on page 365. I would definitely explore the detailed step-by-step guidelines for completing the CMS 1500 form. They also have more information on HIPAA. That would be another site to take a look at. And as I mentioned earlier, there definitely is websites on doing Medicare appeals. And then also for links to individual state insurance offices, there's a website there. You can actually just check them out. Okay. Did I have you do chapter 12, even numbers for homework?
Yeah, you did.
Okay. Why don't we take a few minutes and go over those if you don't have any questions on those chapters. How does that sound? So then let's start back on page 254. So these are answers for chapter 12, page 254, number 2. Where might a patient's diagnosis be located? It can be taken from a variety of sources within the medical record, the clinical notes, laboratory results, radiological results, and other resources. What do you have for number 4, Kelsey?
International classification of diseases, clinical modification, and well, the ICD-9 CM, ICD, yeah.
Yep, you got it. Okay, and number 2 on page 255. When was the first ICD coding system put into use? It was 1900. That's a long time.
Yeah.
Number 2 on page 256. I said you didn't have to do this one, but if you did, it would be 3 to 7 and 3 to 5. Page 261, number 2 is true. Number 4 is true. On page 264, number 2 is mass, if you did it. And number 4 is color coding. 266, NOS, not otherwise specified. It is an abbreviation that is equivalent to unspecified and is used only when there is not enough information. Number 4, what does the bullet symbol preceding a code indicate? This answer depends upon what coding manual is used. In your coding manual, the red bullet tells the coder to use additional digits to ensure the greatest specificity. In other publications, the bullet indicates a new code, category, or subcategory in the tabular list, or a new line in the alphabetic index. Typically, a list of symbols and their meanings are provided in the front pages of the manual. All right. Page 266, actually 269, number 2, which should be coded first, the etiology or the manifestation? Kelsey?
Etiology?
Yes. All right, number 4, coding of sequela generally requires 2 codes with the late effect or sequela sequenced first. Page 270, name the 2 major coding systems of ICD-9. That would be, ICD-10. It would be ICD-10 and PCS. Yeah, ICD-10-CM and ICD-10-PCS. Number 4, provide 3 reasons for changing the ICD-10 coding system. What do you have for that, Kelsey?
I actually put a question mark next to it. I didn't know where that could be found.
Okay. So it should be right there on page 270 to the left in that whole paragraph there. But basically, the 3 reasons for changing to ICD-10 is that it will give us more characters that expands the number of codes that are available to use. A single code can report a disease and its current manifestations in a more precise detail. With more availability of codes, it will be less likely that chapters will run out of codes in the future. ICD-10 uses full code titles reflecting advances in medical knowledge and technology. In fracture code alone, the code differentiates various outcomes with mandatory use of the appropriate seventh character. And ICD-10 codes will also identify the laterality, meaning which side of the body was performed and or affected by the condition. So in a short synopsis, it basically gives us a higher level of specificity all around. Okay? Number 6, how many digits or characters are used in the ICD-10 codes? That would be 3 to 7. Down at the bottom of page 270, if the diagnosis is bronchial constriction, what is the main term, Kelsey?
Constriction.
Yes, it, constriction. Over on page 277, we did those. Number 2, the first character in ICD-10 code is always what?
A letter.
It's an alpha character. Yes, it's a letter. Number 4, what do parentheses indicate in the index? They indicate they have a special meaning. A term that is followed by another term in parentheses is classified to the given code number, regardless of whether any of the terms is in parentheses. Okay, we looked at those codes and what did you learn? We didn't do anything with 284 except maybe talk about how to find the codes. 287, number 2. What did you have for that one? 287, number 2.
I didn't actually write it down in my chapter.
Okay, it's 21. Answer is chapter 21. And number 4 is only the signs and symptoms. And page 289, number 2, coding of late effects generally requires 2 codes. The answer here would be the condition or nature of the late effect sequence first and the late effect code sequence second. And number 4, provide 3 examples of adverse events: tachycardia, gastrointestinal hemorrhaging, vomiting, hypokalemia, respiratory failure. Right. 290, I said you don't need to do those. 291, name the 3 flags used in the gem. Did I say that one? No. List the standard code sets adopted by HIPAA on page 290, right hand side. That would be HCPCS, CPT4, and CDT, dental terminology, ICD-10, and NDC. Over on page 291, number 2, the 3 flags used in GEM. There's 3 of them. Approximate, no map, and combination. Can you tell me what they are, Kelsey?
Approximate direct match between the 2 systems. No map. Similar code between the 2. Combination. Source system must be linked to more than 1 code in the target system to be valid.
Perfect. Excellent work. All right. So how do you feel about those chapters tonight?
Pretty good.
Not too bad, huh?
Yeah.
All right. So let's take a look at next week's assignment.
Do you want us to now do the chapter 12 online quiz?
Yes, do the online exams. All right, and since we're able to get up through 15 tonight, which is good, we can finish 16 and 17 next week. And let's see let me look at hospital billing chapter here for a minute before I go. We might just review hospital billing. It wouldn't hurt. Even though we're not going to do any hospital billing for the national exam, it wouldn't hurt to just kind of go over chapter 18. So for next week, let's finish up with 16, 17, and 18. Do the even numbers in the chapters. We went over
The even numbers for 13 through 15?
yes, sorry.
And then just read 16 through 18.
Yes. Okay.
Yep.
All right. Any questions?
No.
Okay. How about your takeaway from tonight?
Well, I'm glad I found a code. That was fun.
So for next week, you don't really need to bring those books if you don't want to.
Okay.
Okay. You can just bring your health insurance today book and your answers. So you don't have to bring so many. And then after next week, I'll tell you what to bring for the following week.
Okay, and that's school vacation week, right? So are you still gonna have class?
Oh, good question.
I think it's
All right,
that
so
week.
what's today?
Today is the 8th.
So school vacation is the week of the 20th?
I believe so. I'm not positive.
I think
That's just
it
what
is.
the class went by.
Okay, so no, the 22nd. So next week we'll finish the book and we'll have a break before we start the buck book.
Okay.
Okay, so no class. So no class the 22nd.
All right.
And then we come back on the 29th and we start buck book. Okay. So we're going to call it a night then.
Okay.
Is that okay with you?
Yeah, that is.
Okay. So have a great week.
You too. Thank you.
Thank you. Bye.
Bye.